Good morning, dear students. How are you all? Okay, fine, good. Today we can see regarding ARDS. What is the full form of ARDS? Anybody knows? That is Acute Respiratory Distress Syndrome. Okay, we can see it. Okay, before we can go into the objective topic, we can see the objectives of the ARDS. That is the define ARDS, describe the etiology, explain the pathophysiology of ARDS, list down the clinical manifestations of ARDS, then describe the diagnostic test and explain the management of ARDS. We can see one by one. The first, that is the definition of ARDS. What is the meaning or the definition of ARDS? That is, this is one of the respiratory condition. In this ARDS, it is a sudden onset of respiratory failure. This is ARDS is a sudden progressive forms of respiratory failure which is characterized by severe dyspnea, hypoxemia and diffuse bilateral infiltrates. What is the meaning of dyspnea? That means difficulty in breathing. Then hypoxemia, what is the meaning of hypoxemia? Hypoxemia means the oxygen level in the blood is decreased. The definition of this ARDS includes, it is a sudden progressive forms of respiratory failure which is characterized by severe dyspnea, hypoxemia as well as diffuse bilateral infiltrates. Next, we can see regarding what are the other names of ARDS. The ARDS is came to the different names like non-cardiogenic pulmonary edema, then shock lung, wet lung, post-traumatic lung, congestive atelectasis, capillary leak syndrome and adult hyaline membrane diseases. These all names we can call it as for the ARDS. Clear? The next we can move on to the etiological factors. What may be the etiological factors? The etiological factors come into the different headings. Mainly the 3 points. That is, the first one is the direct pulmonary trauma. The next one is the indirect pulmonary trauma. Then the third category, that is the neurological conditions. That first one is the direct pulmonary trauma. How this direct pulmonary trauma is occurred? That is because of some diseases, that is a viral, bacterial or fungal pneumonias. Then lung contusions, then fat embolus or the amniotic fluid embolisms, then the aspiration, then massive smoke inhalation, then inhaled toxins, prolonged exposure to the high concentration of the oxygen. These are all conditions which leads to the direct trauma to the lungs. What are the direct pulmonary trauma? The factors or the causes includes viral or bacterial and or the fungal pneumonias. Then in the lung contusion, fat emboli or the aspiration, massive smoke inhalations, then inhaled toxins, then prolonged exposure of high concentration of the oxygen. Next main category, that is the indirect pulmonary trauma. What is the causes which include in the indirect pulmonary trauma? That includes, first one is the sepsis. Sepsis, then the shock, multi-system trauma, DIC. What is the meaning of DIC? Okay, good. That is disseminated intravascular coagulation. The next is pancreatitis. Then in the uremia, drug overdoses like heroin, opioids, aspirins, etc. Then anaphylaxis. Then increased ICP. These all conditions which can cause indirect injury to the lungs. The third cause includes in the neurological conditions. Some neurological conditions which cause the ARDS includes increased ICP as well as the chronic injury to the or the acute injury into the nervous systems. These all are the main three causes which comes into the ARDS. What are they? What are the three causes of ARDS? Okay, you can tell. Okay, good. That is the three main categories of ARDS. That is the first one is direct trauma, second one is indirect trauma, then third one is the neurological conditions. Next we can move on to the what are the pathophysiological changes which occurs during the ARDS. In that this is also is dividing into three phases. That is first phase, that is the injury or exudative phase. Then second one is the reparative or proliferative phase. Then third one is the fibrotic phase. We can see one by one in detail. Okay. This is the normal alveoli of the lung. During the case of ARDS, the lung becomes like this. Okay. That is, we can see the edema, that is a fluid accumulation in the alveoli cells, as well as the sloughing of the bronchial epithelium. That all things will occur in the ARDS. We can see one by one what are the changes which is occurred during the phases. The first one is the injury or the exudative phase. What is the injury? We already discussed what are the causes. From that causes we can have the injury or exudative phase, that is it occurs within 1 to 7 days. Then initially the patient may have the interstitial edema. Then interstitial edema which leading into the damage to the alveoli cells. Then it causes decrease in the surfactants. Then finally it leading into atelectasis. Then hyaline membrane formation. Then during this stage last it leading into refractory hypoxemia. What is the meaning of refractory hypoxemia? That means irreversible hypoxemia. Hypoxemia means, okay, good, decreased oxygen content in the blood. This all changes is occurred on the first stage, that is the injury or exudative phase. It will occur within the 1 to 7 days. Initially patient may develop the interstitial edema, then the damage to the alveoli, then surfactants will become decreased. Because of the decreased surfactants, the patient may develop the atelectasis. Then hyaline membrane formations, then finally it leading into refractory hypoxemia. Next we can move on to the next phase, that is the reparative or proliferative phase. What are the changes in the reparative phases? Includes, it will begins within 1 to 2 weeks after the initial injury. Okay, this stage will develops within 1 to 2 weeks of the initial injury. Then influx of neutrophils, monocytes and lymphocytes is occurred. Influx of the neutrophils, monocytes and the lymphocytes. Then it will leading into damage to the pulmonary vasculature. It can makes damage to the pulmonary vasculature. Because of this vasculature damage, what is happening? The thickening of the alveolar membrane. The alveolar membrane become thick. Then it can cause us increased pulmonary vascular resistance and pulmonary hypertension. It will leading into the pulmonary resistance of the pulmonary circulation will be, resistance is increased and the pulmonary hypertension is occurred. Finally, it leading into the decrease in the diffusion. The next stage, that is the final stage or the third stage of the ARDS, that is the fibrotic phase. The fibrotic phase means it occurs 2 to 3 weeks after the initial injury. Then it will becomes chronic or the late phase of the ARDS. Then it will cause us the scarring, diffuse scarring and fibrosis of the tissues of the lung or the alveoli. Then decrease the lung complaints and will leading into the hypoxemia will continues. These all are the main 3 phases of the pathophysiology of ARDS. What are the main changes or in the ARDS? Okay, you can tell me. Okay, good. That is the main three phases in the pathophysiology. First one is the injury or the exudative phase. Then second one is reparative or the proliferative phase. Then last one is the fibrotic phase. These all are the main three phases of the ARDS. Next we can move on to the clinical features. What may be the clinical features of the ARDS? A patient with ARDS, what are the features? That is, in the first stage, what are the problems? It may be the ARDS, maybe the baby occurs as a insidious onset. That is a sudden onset of the symptoms. The patient will have these symptoms. That is the insidious onset of the symptoms. Then first of all, the patient will have the dyspnea. That is the difficulty in breathing. Then tachypnea, the respiratory rate will become increased. Then cough and restlessness, fine and scattered crackles. We can hear the crackles, fine or the scattered types of crackles. Then mild hypoxemia and respiratory alkalosis. We can see the respiratory alkalosis in the Abg findings. Then minimal scattered interstitial infiltrate. We can see the infiltrate, minimal scattered infiltrate on the X-ray. Then on to the next stage, what are the features? If the one stage is progressed to the next stage, the patient, of course, the patient may have the increased symptoms. Okay, the symptoms will become worsened. Then respiratory discomfort, tachypnea and intercostal and suprasternal retractions, PFT decreases, then tachycardia, diaphoresis. What is the meaning of diaphoresis? Okay, good. Diaphoresis means excessive sweating. Then changes in the sensorium with decreased menation, cyanosis and the pallor. Then patient will develop diffuse crackles and the rhonchi, that is abnormal lung sounds. Then extensive bilateral interstitial and alveolar infiltrates. Then hypoxemia, that is refractory to the oxygen therapy. That is, what is the meaning of that? That is hypoxemia which is refractory to the oxygen therapy. That is, if we are giving the adequate amount, 100% oxygen also, the patient will not develop the or reverse the hypoxemia. Okay, this is included in the second stage. Then in the late stage, what may be the features? We can see what are the changes or the manifestation during the last stage. That is, it requires enterotracheal intubation and PPV. That is, this is a more extensive stage or the progressive stage of ARDS. Because of this, we need mechanical ventilation. Patient can't able to breathe, patient itself. Then without or the with lung in the X-ray, white lung on the X-ray, then pleural effusion, then severe hypoxemia, then hypercapnia, and finally the patient will develop some metabolic acidosis. These all are the main features, clinical features on the last stage. That are the patient may need mechanical ventilation. That is the ET intubation, or sometimes in the mechanical support is also needed. Then we can see the white lung on the X-ray. Then the pleural effusion, that is a fluid accumulation on the pleural space. Then the severe hypoxemia, hypercapnia, that is the carbon dioxide level in the blood is increased. Then the metabolic acidosis. These all are the clinical features of ARDS. Till this time we discussed regarding the clinical manifestations, that is first stage clinical features, second stage and the third stage or the late stage of clinical manifestations. Next we can move on to the diagnostic assessment. What are the diagnostic assessment? As you all know, for each and every condition we must obtain the history, thorough history regarding the disease condition, present as well as the past history regarding the disease condition should be obtained. Then the physical examination. In the physical examination also we can identify the patient's dyspnea, then the increased respiratory rate, that all things. Then in the other investigations we can see the crackle sound in the auscultation of the lung. We can hear the crackle sounds. That history and the physical examination is very important and mandatory for every assessment. Okay. The next is the Abg analysis. In the Abg analysis, that is also very important to identify the level of oxygen as well as the carbon dioxide level of the blood. Okay. By doing this Abg in the ARDS patients, we can see the metabolic acidosis. Okay. The next in the X-ray, that is very important. In the X-ray, we can see the white snow appearance in the X-ray. This is a normal X-ray. We can see the scarring of the tissues or the lung tissues in the periphery as well as the central part of the lung. We can see this picture. The next we can move on to the management. That is very important. How we can manage these patients, ARDS patients. How we can recover these patients from the ARDS. Of course, we need to have the emergency management of these ARDS patients. That is depending upon the patient's condition. The respiratory support, we need invasive or non-invasive types of respiratory support. We need maintenance of blood pressure, then monitoring the pulse oximetry continuously for identifying any extreme cases of hypoxemia. We can identify by using the pulse oximeter. Then Abg analysis. Of course, Abg analysis is very important to identify the acidosis, metabolic acidosis. Then the blood investigations. According to the patient's condition, we can do the blood investigations. Then in the ECG monitoring is also very important. The next is the first we saw the emergency management or the emergency management. Next we can move on to the supportive management or what are the supporting respiration and ventilation. How we can give the support of ventilation as well as the respiration. That is by using the oxygen therapy with the mask or the cannula that is inadequate. With the help of mask or the cannula that is inadequate, because of that we can use the mask with high flow systems initially. Initially we can give the mask with the high flow of oxygen. Then we can assess continuously the oxygen status of the patient. Then other mechanical ventilations in ARDS patients like invasive as well as the non-invasive types of ventilation, modes of ventilations, that is very important. Then invasive as well as the non-invasive types of ventilations. Then low volume ventilation. Then permissive hypercapnia to expel the carbon dioxide levels. The next, what is the role of PEEP in the ARDS? What is the meaning of PEEP? Okay, you can tell. That is PEEP means positive expiratory end pressure. Okay, good. That is a positive expiratory end pressure. In the olden trends, the olden cases, we can use the high levels of PEEP. But in the newer trend, we are using the low levels of PEEP. Then the other ventilation like open lung ventilation, inverse ratio ventilation, high frequency ventilation and the liquid ventilation. These all are the other ventilation methods. The next we can see the other newer trends in the treatment of ARDS. What are the other newer trends? That is a beta agonist. We can use the beta agonist for treating the ARDS patients. That is beta agonist like terbutaline, inhaled salmeterol and intravenous albuterol. These all are the beta blockers which can use the patients with the ARDS. The next is the exogenous surfactant therapy. What is the exogenous surfactant therapies? That is we are administering the surfactants to improve the lung function of the patient. That is, in the adults, significant improvement in the oxygenation it can cause us within the 24 hours. This is also very effective in using with the neonates. Then the other medications like inhaled vasodilators, then nitric oxide and the prostacyclines also we can use for the ARDS patients. The next is the extracorporeal techniques. We can use the extracorporeal techniques for the ARDS patients, like that is extracorporeal membrane oxygenation, that is the ECMO, then extracorporeal carbon dioxide removal, that is ECCO2R. These all are the main extracorporeal techniques which can use for the ARDS patient. The next is the anti-inflammatory therapies. Of course, we need to have the anti-inflammatory drugs for the patients for treating the ARDS. Okay, that are the corticosteroids, prostaglandin E1, then neutrophils, elastin inhibitors, that is the civilast, ketoconazole, arachidonic and acid inhibitors, then the ibuprofen. These all are the main anti-inflammatory drugs which can use for the ARDS patient. The next is the antioxidants. Antioxidants is also very effective in the ARDS. That is antioxidants like N-acetylcysteine, then the paroxetine. These all are the main antioxidants which can use for the ARDS patients. Then other medications, others like lysophiline, dietary oil supplementation is also effective in the patients with the ARDS. The next is the position strategies for patient with the ARDS includes the prone position. We can provide this, you can see this image, isn't it? That is, this is a prone position we can provide for these patients to improve the oxygenation as well as to expel the secretions. Then other position strategies like continuous lateral rotation therapy, that is with the help of the machines on the bed itself, we can provide the continuous lateral rotations to mobilize the secretions of your patient. The next is kinetic therapy. These all are the main positions which can use for the ARDS patients. The next is the maintenance of cardiac output and the tissue perfusion, how we can maintain the cardiac output as well as the tissue perfusion. That is a continuous hemodynamic monitoring, that is very, very important. That is for identifying any variations on the vital systems. We can do the hemodynamic monitoring. Then ionotropic drugs like dopamine, dobutamine is also very effective for the treatment of ARDS. Then the fluid monitoring, you must identify the fluid levels of your patient. The next is the very important point, that is to treat the underlying causes. That is very, very important. What is the cause which can increase or which causes the ARDS? That is very important. That is antibiotics. If patient having any infections, we can provide the antibiotics. Then large doses of corticosteroids, that is a controversial. Then the fluid management, that is without any diuretic therapy. The next is most important part, that is the complications. Of course, if the patient develop any diseases, it will have the complications. That is the complications, mainly the infections. It is very, very important to have the infections, this ARDS patients, that is catheter related infections, then the hospital acquired pneumonia, then the sepsis, that is, or the bacteremia can occur. The next respiratory complications like oxygen toxicity. Sometimes the patient, with the introduction of the high flow oxygen, the patient may develop the oxygen toxicity. Then pulmonary barotrauma, then the pulmonary emboli, that is the emboli formation on the pulmonary system. Then in the pulmonary fibrosis, that is the fibrosis formation on the pulmonary system. Then the VAP. These all are the main complications. What is VAP? That is ventilator associated pneumonia. The next is the GIT complications. Are you following me? Okay. GIT complications like paralytic ileus, because of the decreased mobility, the patient will have the paralytic ileus. Then the pneumoperitoneum, stress ulcerations, hemorrhage, then hypermetabolic state and the dramatically increased nutrition requirements. The next complication, that is the renal complications, that is patient may develop the acute respiratory failure. Then cardiac complications like dysarrhythmias, the patient will develop the dysarrhythmias, then decreased cardiac output. Then next is the hematological complications. Hematological complications like anemia, DIC, that is disseminated intravascular coagulation, then thrombocytopenia. These all are the main three complications which occurs in the blood or the hematological system. The next is the ET intubation complications. The patient may be on the ventilator, of course, they were on the ventilator. Because of that, the prolonged ventilator, the patient will develop the ET intubation complications like laryngeal ulceration, then tracheal malacia, then tracheal stenosis, then the tracheal ulceration. The next is psychosis or the psychological complications like delirium, sleep deprivation and the PTSD, post-traumatic stress disease. That is the psychological complications like delirium, sleep deprivation and post-traumatic stress disorders. The next, the final stage or the last stage of this condition, that is the nursing management. That is very, very important in our side. Okay, what may be the nursing diagnosis which is occurred with the patient with ARDS? Okay, you can tell me what are the some of the nursing diagnosis which comes in the ARDS patient. Okay. Okay, good. That is, we can see the management, nursing diagnosis along with this ARDS, that is impaired gas exchange related to underlying illness. That is very, very important nursing diagnosis, that is the impaired gas exchange because of the infiltrate formation on the lungs. The patient will develop the ineffective gas exchange or the impaired gas exchange. The next is ineffective airway clearance. Ineffective airway clearance because of the increased secretion, mucus production will cause us the ineffective airway clearance. Then decreased cardiac output, which is related to the decreased venous return secondary to the ventilator. The next is the excessive fluid volume related to the non-cardiogenic causes. Then risk for the trauma and infection related to the endotracheal intubation. Then impaired physical mobility related to the ventilator dependence. Then risk for complications related to the ventilator. Then impaired verbal communication related to the ET intubation and the attachment to the ventilator. These all are the main nursing diagnosis. The next we can move on to some of the research evidences with the ARDS, that is enriched with omega-3 fatty acids which improve the clinical outcome of the patient with ARDS. That is, with the use of omega-3 fatty acid, we can improve the clinical features or the clinical symptoms of your patient. That is one of the research evidence. Then another one of the research evidence, that is the prophylactic COL3 administration has been shown to be effective in the ARDS treatment. Then last one is the modest doses of corticosteroids which have the significant improvement in the ARDS. These all are the research studies which is related to the ARDS. Okay, till this time we discussed regarding the ARDS, what is ARDS, then what is the definition of ARDS, then what are the etiological factors. The etiological factors means mainly the three causes. First is the direct trauma, indirect trauma, and third one is the neurological conditions. Then we move on to the pathophysiological changes. The pathophysiological changes is also occurred on the mainly the three phases. The first phase, that is the fibrotic phase, then second is the second stage, then the third phase. These are three phases. Then we move on to the clinical features of the ARDS. Then the stage by stage, first stage, second stage and the late stage or the third stage. Then we discussed regarding the diagnostic measures of the ARDS. We saw the management, that is the first one is the emergent management. Then we saw the mechanical support, then the nursing management. That is very, very important. Then we saw the related studies with the ARDS, the patient with the ARDS. Anybody is having any doubts? Anybody is having any doubts? Okay, thank you.